Hi, this is Brian Kim. I'm going to share with you this case of a patient with a secluded pupil and silicone oil in the eye. This patient was referred from a retinal specialist who had retinal detachment, silicone oil placement. And so you're going to see the silicone oil is pushing up, shallowing the anterior chamber. And also, again, there's a secluded pupil. You're going to see stripping of that pupillary membrane, trypan blue, and then mechanical fracturing of a white cataract in this context with that shallowing chamber and utilizing mechanical fracturing techniques to very safely and efficiently disassemble this white lens. So you can see the pupil is secluded. Use a corneal marker, which helps me to center and size the rhexis. I make my paracentesis incisions first on the right side and then the left side, making sure I'm parallel to the iris plane so I can achieve a nice self-sealing incision. This is intracameral lidocaine, some intracameral epinephrine as well. So here I'm pushing BSS and trying to get the pupillary edge off the anterior lens capsule, trying to see if I can get a little bit of an edge there so I can try to visco dissect the pupil off the lens capsule. But it's quite adherent, like you can see here. I did get one area of opening, so I go ahead and push some viscoelastic underneath that edge there, and I'm filling the anterior chamber with the viscoelastic. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then using the cannula to turn the eye towards me, and then I enter. So again, I'm using the viscoelastic cannula, trying to get underneath that edge. And you want to make sure you're not pushing too much viscoelastic here because you're just going to burp it out of the wound. And plus, you might accidentally cause the iris to prolapse out. So this is really more a mechanical sweeping maneuver, pushing a little bit of viscoelastic as I do it, but again, being very judicious and sparing with the viscoelastic. So this is a two-handed technique. In the left hand, I have microforceps, and then my right hand, I have my capsulorhexis forceps. And using a two-handed technique, I'm going to peel off that pupillary membrane, peeling it with the capsulorhexis forceps, and stabilizing the pupillary edge with the microforceps in my left hand. Here, it's a little bit difficult to grab, so I'm just using the closed teeth and just pushing down on the iris as I'm pulling with the capsulorhexis forceps here. You can see the pupillary membrane is peeling off in bits, and so I'm having to grab again and again here. Again, using the microforceps to stabilize the pupillary edge, because what you don't want to do is keep yanking on the iris and then actually cause trauma to the iris root, which can happen in some cases. So by grabbing the pupillary edge with the forceps, you just have much more control and potentially less trauma to the iris. So this is intracameral air. Of course, you have viscoelastic already in the chamber, so that's why you have to paint the anterior capsule surface with the trypan blue, as you can see in this situation. And this is some more dispersive viscoelastic. You can see now the pupil dilates much, much larger. And unfortunately, the trypan does not actually stain in the more peripheral lens capsule here, but that's okay. Use a cystotome to puncture. You can see there's not much milk, so this is not really an intumescent lens. And these are the blunt tip Halti-Percar, so that's why, again, I use the cystotome here. You can see this is like a two-tone capsule now because I did not stain the peripheral capsule. I'm pulling centrally just a little bit just to make sure it doesn't radialize. So again, I'm applying some central forces as I make the rhexis here. So it's complete. And in these cases, with the white lens, usually the lenses are quite mobile, but this is the capsular fornix hydrodissection technique. I place the cannula underneath the rhexis edge contra-incisionally. Of course, you don't see a wave there, but you can see the lens spun quite easily. Lift the incision with the chopper, go in with irrigation off to minimize decimase trauma, removing the surface epinuclear material. You can see the lens spinning quite freely here. But what you're seeing now is I have a little bit of that iris pupillary membrane strand is coming to the phaco tip. So I come out with the chopper, push some more viscoelastic in, and then I'm going to use some microforceps to grab that little remnant of the pupillary membrane because it kept coming to the phaco tip when I was using the vacuum. So I peel it off, go back with the chopper, remove some more epinuchal material, place the chopper underneath the rexus edge contra-incisionally. Quite a bit of milk comes out. Position the phaco tip vertically sub-incisionally. Bring both instruments together, fracturing the lens completely in half. That's double chop. Place the chopper around the right heminucleus, turning the chopper vertically, crushing the lens against the phaco tip, and that is the cross chop maneuver. So this is really very helpful in these cases. When you have a white lens and it's essentially freed from the bag, there's no epinucleus, there's no cortex. This is essentially like a Morgagnian cataract situation. You have a high risk for posterior capsule rupture. If you try to go after lens pieces with high vacuum, you can definitely snag the posterior capsule and then have a complication. But by using mechanical fracturing forces to sandwich and crush the lens pieces, again, with not using any vacuum, not using any ultrasonic energy, I'm just using crushing forces to crush the lens between the instruments, as you can see here, very efficiently and very easily. I have exquisite control over the eye. I'm crushing the lens pieces, again, not utilizing any high fluid movement, vacuum, aspiration, no ultrasonic energy. My risk of rupturing the posterior capsule this way is extremely, extremely low. So I have tremendous control. I'm able to get around the lens pieces with the instruments, crushing the lens piece between the instruments. I can feel the tactile fracturing of the lens pieces between the instruments, using some vacuum to position the lens piece as needed on the phaco tip, and then again sandwiching and crushing the lens pieces between the instruments again and again until they're small enough, using the chopper to protect the posterior capsule and using pulses of ultrasonic energy and vacuum to disassemble the lens. So you can see here, despite a shallow chamber and despite having a freely mobile dense nuclear piece, I'm able to disassemble the lens safely and efficiently. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. You can see there's dense amounts of capsule fibrosis. I'm polishing underneath the rexus edge. You can see the reflection of the silicone oil in the vitreous space. It's very shiny. It's really difficult to even see the posterior capsule or the anterior capsule because of that reflectivity of the silicone oil. But I go ahead and polish anyways, going around making sure I'm in the polish mode, which makes this very safe. I use a BSS cannula to pulse the subincisional capsule fornix. You can see that little piece of cortical material flying out. So I was able to loosen that up. Go ahead and push some cohesive viscoelastic to fill the bag before I come out with the INA. And then I'm going to go ahead and sweep underneath the rexus edge, first on the left side and then the right side. Again, this is a fairly clean looking bag otherwise because this was a mobile white lens, but you see that dense fibrotic material on the posterior capsule. I'm going to put a 3-piece lens in, so this is widening the incision with the blade, going in with bevel down, turning the bevel to the left, delivering the leading haptic, making sure it goes into the capsular bag. As the optic is delivered, rotating my wrist 90 degrees counterclockwise, letting the trailing haptic come out outside of the eye, and then dialing the trailing haptic into the bag with the Maltzman using the optic haptic junction. Going in with irrigation off, activating irrigation. With the eye inflated, I go underneath the lens, removing the viscoelastic from within the bag, repositing the optic back down, polishing under the rexus edge once again, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you saw this patient who had a retinal detachment, silicone oil, secluded pupil, stuck to the lens, white cataract, shallow chamber. And so I was able to use a two-handed maneuver to peel off the pupillary membrane off the anterior lens capsule using microforceps and my capsular rhexis forceps. And then I had to paint the anterior capsule surface with trypan blue. It didn't do a great job, but it was able to at least give me some level of visualization. I had to pull centrally a little bit as I went around to make sure the rhexis didn't radialize. Again, because of that silicone oil pushing up on everything. Again, this is essentially like a Morgagnian cataract. There's very little cortex, very little epinuclear material. And so utilizing mechanical fracturing techniques is really quite advantageous. You're not going after lens pieces with high vacuum, which again, suppose your capsule is exposed in this situation. Using mechanical fracturing by crushing the lens pieces without the need for ultrasonic energy or vacuum makes this very safe and also very efficient. And again, this was a pretty dense nugget of an endonucleus, but we're able to efficiently remove it, finish off the case, putting the three-piece lens into the capsular bag without any difficulty. And so this is why I feel like mechanical fracturing has so many advantages in so many scenarios, especially and in particular this type of case with a secluded pupil, shallow chamber, silicone oil, and a white mobile cataract. So I hope this was helpful to you, and I thank you for your attention.